Today, Kristen and I are going to talk about lung cancer. First off, the general overview is that lung cancer is second only to prostate and breast cancer as the most common type of cancer in men and women, respectively. There are two types, which include small cell and non-small cell lung cancer. Small cell lung cancer is split into two stages, including limited stage, where the cancer is only found in a small part of the lung and lymph nodes on one side of the chest, and extensive stage, where it begins to spread to both sides of the chest and other organs. On the other hand, non-small cell lung cancer is split into four stages depending on the size and spread of cancer tumors as well. And the ribbon color for lung cancer awareness is white. Next, we have the signs and symptoms of lung cancer. Usually there are no signs or symptoms early on, but people with lung cancer will eventually develop these symptoms. These include new and/or persistent cough, coughing up blood, chest pain or infections, breathlessness, weight loss, and fatigue. So as many of you know, smoking is the #1 risk factor for lung cancer, and it has been linked to 90% of lung cancer deaths. Other risk factors for lung cancer include the inhalation of hazardous material such as radon and asbestos. A person's age is also a risk factor, which we've seen is the case in a lot of cancer types. Pulmonary fibrosis and other lesion-forming diseases can also be risk factors because they cause lung damage. And lastly, family history of lung cancer can also be a risk factor, although its genetic basis is still not fully understood yet.
Who is at risk? In general, men have a greater chance of developing lung cancer and of dying of lung cancer. The majority of people who are diagnosed with lung cancer are over 65 years of age, and the mean age of death from lung cancer is 70 years. The general statistics: there are 228,820 new lung cancer cases per year, and about 50.8% of those are from men. And there are 135,720 deaths per year, and about 53.4% of those are from men. The statistics of non-small cell lung cancer. So 84% of the total lung cancer, are non-small cell lung cancers. The 5-year survival rate indicates the percent of patients who are still alive 5 years after their diagnosis. The localized for non-small cell lung cancer is at 61%. And this means that there are no signs that lung cancer has spread outside of the lung. The regional for non-small cell lung cancer is 35%. And this means that the cancer has spread outside the lung to nearby structures or lymph nodes. Distant for non-small cell lung cancer is 6%. And this means that the cancer has spread to distant parts of the body, such as the brain, bones, liver, or the other lung. The all-SARE stages of non-small cell lung cancer is 24%, and this stands for Surveillance Epidemiology and End Results, and this is a program that collects data on cancer statistics. And then the statistics of small cell lung cancer. 13% of all lung cancer cases are small cell lung cancer. The 5-year survival rates are localized at 27%, regional at 16%, distant at 3%, all SARE stages at 6%, and small cell lung cancer has a much lower 5-year survival rate compared to non-small cell lung cancer. And this is looking at localized, regional, distant, and the all SARE stages.
diagnose lung cancer, a variety of tests may be done. These include imaging tests such as X-rays and CT scans, which you can see here. Sputum cytology, where a sample of mucus is examined under a microscope for abnormal cells. Or biopsy, which can include bronchoscopy, where a lighted tube is passed through the lungs through the throat to examine them. Mediastinoscopy, where a small cut is made to take a sample of the lymph nodes. And image-guided needle biopsy, where a needle is used along with an imaging test to obtain a sample of the lymph nodes.
So looking at the KRAS pathway, many growth factors turn on the KRAS pathway, including SSH, TGB beta, and several other signals. In many lung cancers, about 25 to 40%, the KRAS has a mutation that continuously activates it. Smokers have been observed to have KRAS mutations in 0 to 15% of lung cancer cases. KRAS turns on PI3K, RAF, and RAL-GEF pathways. These turn on other proteins that eventually lead to the survival, proliferation, and cytokine production, and contribute to the malignancy of the cell. When KRAS becomes oncogenic, it can produce molecules such as cancer-associated fibroblasts, inflammatory cells, T and B cells, and myeloid cells, which promote cancer. And this is telling us that it is one of the most common mutations, the KRAS pathway, and then the downstream pathways have important roles in the development of lung cancer.
It has also been found that the alteration of the Wnt pathway plays a role in the development of lung cancer. And we've talked about the Wnt pathway a lot in class, but one protein that the paper I read specifically focused on was CTNNBIP1, which, as you can see from the chart here, is a tumor suppressor gene that's known to repress the transactivation of beta-catenin. As we know from class, beta-catenin is responsible for activating the expression of many downstream genes. One of these that was focused on in the paper is MMP7. MMP7 is a protein responsible for degrading cell adhesion molecules, which is necessary for normal processes, including embryonic development and tissue remodeling. But in tumorigenic cells, MMP7, if it's increased, can lead to decreased cell adhesion and therefore increased migration capabilities. In this paper, they hypothesized that they would find an inverse relationship between promoter hypermethylation and mRNA levels of CTNNBIP1. They also hypothesized that this low level of CTNNBIP1 expression would lead to increased beta-catenin transactivation, which would then lead to increased MMP7 and that decreased cell adhesion and increased migration capabilities. The results of this study found that there was a decreased amount of CTNNBIP1 mRNA in tumor cells. In these same cells, it was found that there were high levels of promoter hypermethylation. If you look at the graphs at the bottom left of this slide, you can see that mRNA levels of CTNNBIP1 are decreased in tumor cells compared to the normal cells. And then in the second chart, you can see that in the cells with decreased mRNA of the CTNNBIP1 are also highest in promoter methylation. They also found that in 3 tumor strains, there was increased migration ability without the expression of CT-NNBIP1. So if you look at the top graph in this case, here are the 3 strains of tumor cells, and they ectopically express CT-NNBIP1 in these cells, and you can see both quantitatively and qualitatively that where CT-NNBIP1 is expressed, they have different migration abilities. Lastly, they also compiled data from lung cancer patients and found that there was a statistical significance between low levels of CT-NNBIP1 and increased levels of MMP7. They also found that decreased CT-NNBIP1 expression was linked to the fact that the patient was a smoker, which, as we mentioned earlier, is a known cause of lung cancer. Lastly, they also found that low CT-NNBIP1 expression was associated with the pathological stage of the patient's cancer. This shows that there's also potential to use CT-NNBIP1 as a prognostic biomarker for tracking the progression of a patient's lung cancer. And here we have a summary slide of both how the Wnt pathways and KRAS pathways interact with beta-catenin and the downstream target genes. Here we can see that the Wnt pathway inhibits the expression of target genes and KRAS pathway activates their expression, which allows for regulation in a normal functioning cell. However, when these pathways aren't functioning correctly, it can lead to tumorigenesis.
So this was my article that I focused on, and it explores the possible immunotherapies of monoclonal antibodies for non-small cell lung cancer. And they looked at several immune checkpoints which were targeted, such as apoptosis, autophagy, and the NF-κB pathway. Tumor proliferation was found to be lower in mice that were also treated and also increased the T cells. The study concluded that the mice treated with monoclonal antibodies had less tumor growth than the controls. And then, as you see in the figures, in figure A, it looks at the BCLIN1 protein levels, and these play a role in cell death, and were about the same in both the control and the mice given antibodies in. And in figure B, it looks at the P62 levels, and these play a role in the autophagy, and they were lower in mice that were treated with the antibodies. And in figure C, which looks at the LC3B2 and the LC3B1 ratio, this also plays a role in autophagy, and it was much lower in the control group compared to the mice that were treated with the antibodies. And this is a graph that just summarizes the pathways that the antibodies inhibit. So tumors inhibit the activation of CTLs through TREGs and allow cancer cells to survive. The B7 on antigen presenting cells interacting with CD28 receptors on the CTL cells lead to the production of T cells, and then that leads to an immune response. If the B7 on antigen presenting cells interact with the CTLA-4 receptors on CTL cells, this leads to suppression of the immune response, and that allows for tumors to form. And then, so by using the CTLA-4 antibody inhibitors, these pathways can be blocked, which leads to an immune response. The PD-1 on active T cells and binding with PDL PD-1 inhibits anti-tumor activity. The PD-L1 inhibitors block this pathway, and that leads to an immune response. And so basically the monoclonal antibodies were used to restore the CTL anti-tumor activity. And so that inhibits cancer development. So what is unknown about lung cancer, and what are some future directions we can look into? So the study I looked at suggested that we study each pathway to determine whether the pathways contribute to reduced tumor proliferation or if they contribute to increased tumor degradation. And then also suggested that we identify driver genomic aberrations and simultaneously develop effective targeted therapies. And this could be done through the use of genomic analysis to identify different targets.
Next, we have the current therapies of lung cancer, which can rely heavily on the type and progression. Sometimes these treatments are even combined for patients with more advanced stages of lung cancer. One option is to undergo surgery, in which there are a few different types depending on the cancer spread, as you can see from the graph here. In a wedge resection, a small part of the lung containing the tumor is removed. In a segmental resection, a larger portion is removed. A lobectomy is characterized by the removal of an entire lobe of the lung. And lastly, a pneumonectomy is when the entire lung is removed. Next, we have radiation, in which energy beams, usually X-rays, are used to kill cancer cells. And then stereostatic body radiotherapy, which is basically radiation treatment, but using multiple beams of radiation at different angles on the cancer. Chemotherapy, which is the use of drugs to kill cancer cells, and these usually come in the form of an oral or intravenous drug. Targeted drug therapy, which is the use of drugs to target specific abnormalities in the cancer. And lastly, palliative care, which involves working with a physician to help mediate some of the symptoms of the cancer. And here we have some novel therapies of lung cancer. These include immunotherapy using monoclonal antibodies, as Kristen was talking about. So in this, we have immunomodulators, which target many different mechanisms that lead to immunotherapies. Monoclonal antibodies are used to restore CTL anti-tumor activities. Killer cells and other immune cells target the tumor cells using antibodies. This leads to antigen-presenting cells activating T and B cells and leads to the production of more antibodies. And secondly, we have epigenetic control therapy. A specific example of this with the paper I just talked about is finding a way to increase the expression of CTNNBIP1, or by further researching different factors that affect the pathway, such as agonists or antagonists of CTNNBIP1. Some good examples of epigenetic control therapy are developing drugs that inhibit DNA methylation or histone deacetylation. And these have been studied in connection to a wide variety of cancers. One concern with this, however, which we've seen has been a concern with many cancer treatments, is the lack of specificity of drug inhibitors. For example, we wouldn't want to inhibit DNA methylation in healthy cells because methylation is essential for normal biological processes as well.
So the take-home messages. So small cell lung cancer and non-small cell lung cancer are the two main types of lung cancer that we usually see. And small cell lung cancer has a much lower survival rate compared to non-small cell lung cancer, as we talked about earlier in the statistics. And then, as Claire talked about, and from what we talked about in class, lifestyle choices your gender and age can also affect your risk of lung cancer. And then also we talked about earlier the KRAS and Wnt pathways, which have been observed to work together to cause lung cancer. And then some current therapies include surgery and chemotherapy, although there are many other different types of therapies that are typically used. And then some novel therapies that we were discussing include immunotherapy and epigenetic control. And then these are our references.